Good afternoon, everyone, and welcome to our webinar. I'm Angela Jones. I'm the Chief Operating Officer for Monash Partners Academic Health Science Centre, and it's a great pleasure to welcome you to our session today, The Power of Learning Health Systems, Connecting Data, Research, Translation and Healthcare Improvement. The purpose of coming together today is to present and discuss how to improve health outcomes across our community through data-driven innovation and care. Before we begin, I'd like to acknowledge the traditional custodians of the land and waterways on which our Australian partners stand and on which we're all meeting today. We pay our respects to these cultures, their elders past, present and future, and continue to uphold their ongoing relationship to the land. I'd also like to pay my respects to any Aboriginal and Torres Strait Islander people joining us for our presentation and webinar today. Before we move on to a series of presentations, a little bit of a very brief overview of Monash Partners for some of you that may not be familiar with our work. We're a partnership of 12 organisations. We bring together health services, research and teaching organisations. Collectively, our partner organisations serve the health and wellbeing of about 3 million Australians, predominantly throughout the southeast corridor of Melbourne and Victoria. Under our partnership, we have about 57,000 healthcare professionals, almost 1 million hospital admissions across our health service partners, 723,000 emergency department presentations, and a very, very substantial research budget. Our purpose is to connect researchers, clinicians and the community to innovate for better health for the community that we serve and well beyond that as well. It's no surprise to any of us that our healthcare system is incredibly siloed, and the role of Monash Partners is to try and bridge some of those silos and provide a space for genuine collaboration. This is our strategic plan at a glance. Our plan is built around 4 pillars. Our number one strategic priority is data-driven healthcare improvement. Our other priorities are leading theme flagships that directly benefit our community, strengthening health services research and implementation, and supporting clinical innovation through to research and impact. We also have established under our partnership some clinical themes and enabling platforms. A number of our enabling platforms directly support the learning health system work that we're going to present to you today. And those of particular relevance are consumer and community involvement, data-driven healthcare and informatics, and health services research and development implementation. A little just about our data-driven healthcare improvement platform. The purpose of this platform is to improve health outcomes across our community through data-driven innovation and care. I would encourage you to go to our website where there's a lot of information about the various initiatives. Just to reiterate, and Helena will describe this a little bit more in her presentation in a little while, but we've established nationally agreed priorities in data-driven healthcare improvement through a rigorous process. The number one priority through that process was creating learning health systems to stimulate partnerships across academic, clinician and industry stakeholders. There are also priorities more specific to the Monash Partners platform, recognising the strength in our lead academic partner, Monash University, through the Monash University Helix data platform. As I mentioned, there's also a web page dedicated to our data platform that describes some of the key projects that we've led under this platform over the last 3 years. Obviously, there's further details about the learning health system. There's a guide and an implementation tool. There's also been a large body of work progressed around data sharing across our partner organisations, a project that we're leading around artificial intelligence using a learning health system approach, and some exemplar projects funded through the Victorian Collaborative Healthcare Recovery Initiative, and we'll be hearing about some of those projects as well today. Alison Johnson is the project manager for our and leads and coordinates our data initiatives, and it would be delighted to hear from any of you. So today's event, I think, is particularly exciting for Monash Partners. It's a culmination of about 2.5 years of work around developing the learning health system. Today we have a series of presentations providing an overview of the learning health system, and then also some examples of some projects that are being progressed in Victoria and also in Queensland, with a really very distinguished group of presenters. My role is to facilitate this first part of the session, which will be a series of presentations, and then we'll move on to a panel discussion where there'll certainly be an opportunity to put some of your questions and comments to our panel members. Just to remind you, our session today is being audio and video recorded, and we'll make a copy of it available through the Monash Partners website post this event. We would encourage you to provide your comments. Members of the Monash team will be monitoring the chat and the Q&A throughout the event. If you have questions for the panel, could I encourage you to post those in the Q&A rather than the chat? And also you have the opportunity there to vote up or prioritise your questions or those of others using the thumbs up. At this point now, I'm going to stop sharing my screen and hand over to Professor Helena Teed. Helena is an endocrinologist at Monash Health, and she is also Executive Director of the Monash Centre for Health Research and Implementation and Executive Director of Monash Partners Academic Health Science Centres. She holds a number of leadership roles across healthcare research and policy, and Helena is going to provide us with an overview of the learning health system approach and describe the journey that we've undertaken over the last 2.5 years as a Monash Partners team. Helena, over to you.
So as Angela said, we've got a panel today where we're going to talk you through the development of an evidence-based framework for learning health systems and the approach. And then we've got some great input from experts, including Wendy Chapman and Claire Sullivan, who are also working in the learning health system space, and then some pragmatic examples of application of the learning health system, and then a panel that's over to you. So I'm going to take you on the journey of why the learning health system framework that we've developed looks the way it does. And the most important thing to start by saying is it's not because we just drew it like this, or indeed that we took any one existing framework that was out there. And we actually have developed this iteratively in an evidence-based way. So we have an Australian Health Research Alliance, which includes the 10 NHMRC accredited research translation centres across Australia. These centres are charged with implementing or embedding research into practice to deliver better health. They're aligned with the National Health and Medical Research Strategy, and the primary purpose is to have healthcare fully informed by research, and also directly aligned with the purpose of the Medical Research Future Fund. We came together several years ago when we were accredited, and we had 4 national initiatives, and one of them was data-driven healthcare improvement, in which we've engaged with all other major federal data initiative stakeholders. We had a formal priority setting process in 2018, and without going into great detail, because this work is published in the MJA, as Angela mentioned, there were 3 key priorities. The first of which was to create virtual or actual health data or research incubator hubs that directly drive healthcare improvement. The aim in working through this, and Monash Partners led this work in collaboration with several of the other centres, was to identify an evidence-based approach to integrate data hubs into healthcare to deliver health impact. So in developing up the approach, it also needed to be evidence-based, not simply evidence-based initiatives or projects from cystic fibrosis or cancer, but actually what was the system and how do we take the most rigorous evidence-based approach to that to be able to drive a learning health system environment. So we formed a steering committee. We had national engagement through the National ARA, or Healthcare Research Alliance Committee. We brought in all of the major data stakeholders and relevant experts. We undertook an extensive systematic review I'll speak about, then qualitative interviews with leaders and experts around Australia and internationally. We worked with national and international thought partners, had a co-design workshop, then have been piloting implementation and are now on to doing extensive funded system optimisation to actually work through the learning health system. So in a very brief summary, the systematic review that's published, we went from research data hubs to the learning health system approach based on what the evidence was able to provide us. Of 177 papers that were captured, and the data here is exponentially increasing, what was clear was we were capturing opportunities where actually they had taken data through to impact in healthcare. So we were not looking at theoretical model development, we were not looking at just research or just healthcare, but how had someone used data and research together to actually deliver better healthcare with measurable impact. And there were relatively few of those. But of those, we looked at the core components. We then did those extensive qualitative interviews and extracted the core learnings about how we do this, having systematic frameworks that are iterative, making sure we have all stakeholders at the table, having a skilled workforce that works together across all the components that are critical here. You cannot simply have data analysts or digital health experts or clinicians or community or funders. You need everybody together. It does require resources, but often if it's done well, it will generate savings that can sustain the systems. It requires data systems and processes. And one of the things we discovered in the learnings was there were many models out there. Almost all of them did not engage with stakeholders. So they were either research driven and they only focused on the data component and analysing data and producing it to then be implemented, or they were embedded in healthcare and didn't look at evidence and best practice. Very rarely did they set priorities with stakeholders. So they were isolated in different silos and they weren't necessarily integrated. So we took all of that evidence and some examples through an interactive workshop, again with broad stakeholders, and brought that together into a learning health system framework. The agreed purpose of that, and that was several years' work, the agreed purpose of that was to improve health outcomes across our community through data-driven innovation and care. And the learning health system was defined as learning together with stakeholder engagement, best research-driven practice, data-driven healthcare improvement that's implemented and delivers better healthcare. And the structural components, if you like, were around evidence from stakeholders, and you can see that the wheel here, first quadrant being the evidence from stakeholders, community, government funders, or organisations that have to implement this, academics and clinicians. What is the collective problem? What are the priorities we're going to work on? What are the outcomes? The patient-reported outcomes, patient-reported experience measures, value-based outcomes, quality outcomes that we need to work for. Then what is the best research evidence? What is the evidence from data? And then what is the evidence from implementation? And I have to say on this journey, especially engaging different specific content areas like diabetes, maternity care, many others, what we find again and again is, in fact, occasionally people ask the stakeholders, often they'll bring in research evidence. They'll often do quite a bit of work in this benchmarking, and clinical quality registries are a classic example, but they stop here. And in fact, there are 10 years of really good registries and really good data collections that are national and expensive that have actually showed no improvement. Some do, but many don't. They simply stop at that point, sits in the research or the data silo, and doesn't reach through to implementation, which are totally different stakeholders and totally different skill sets. So this is about bringing all of those together in an integrated way. So the objectives of the system, the work that fell from this, was that it must be embedded, research embedded in healthcare and in a system, integrating all of those different silos, making sure we understand and bring together the stakeholders, making sure we bring in best practice from research. I say that because we held a forum probably 18 months ago now with Helen Bevan, who is the head of NHS Innovation England, and we had 200 implementation quality improvement people from our health services in the audience. We asked them how many of them use research and evidence, systematic reviews and guidelines in their quality initiatives. And in fact, one actually raised their hand to say it was a critical component. So there's a real barrier between taking the research, and I'm happy to have this discussion with anyone, but a randomised controlled trial does not automatically change clinical practice. A guideline doesn't automatically change clinical practice. So how do we bring that evidence from research into here? This little black box here, and many of us will talk about this today, is the critical systems and processes to take data from our routine care or our registries and take that practice to data meaningfully, then analyse that data to new knowledge. And then the last quadrant is taking that new knowledge or evidence back into improvement. So ultimately we can improve the rate, speed and effectiveness of change from prioritised areas based on good evidence that's data-driven and measurable and leads to improvement. So it was agreed that the benefits needed to be to multiple stakeholders. And if they're not to multiple stakeholders, we will fail to embed this in a meaningful way. The principles, again, that emerged from that rigorous process were that this is largely about people. There is the available software, and whilst it requires improvement, adaptation and implementation, there's a plethora of technological solutions to a lot of this, but most of the barriers are around creating a system for us to work together and bringing people together. It was found very much so that for these to work, it required culture, trust, transparency, partnership and co-design. They're easy things to say, but they often don't occur. And one thing that did become clear is that often government-driven learning health systems don't necessarily achieve this, because government is often seen to be primarily beholden to budget or value or to a top-down approach, as opposed to partnerships, and academic health science centres were successful examples of those, like our research translation centres, or partnerships in particular areas like in cystic fibrosis or in stroke. So partnerships were much more successful than initiatives that were driven by one organisation or one stakeholder. Agreed standards and guidelines and governance was important, as was resources. So all of these things need to be considered if you're actually going to make this work. So without going into this in great detail, and there is both a document that explains all of this on the Monash Partners website, as well as an implementation guide, as well as all the published references I've referred to. But to give you a bit of an idea of how we're working through implementing or building this system, is that in terms of the first quadrant, we've been working with policy leaders. The Victorian government, the South Australian government and the Queensland government have all committed to implementing a learning health system, and we're seeing that cascade to other jurisdictions. It's a priority that's funded in the UK. There are many organisations in the US that are already implementing this. So engaging our policy leaders has been critical, and we're working with them across multiple jurisdictions. We're working with our CEOs, and indeed at Monash Partners have got our CEOs to align around the importance and the implementation of the learning health system, working with other stakeholders and with our consumers throughout the whole journey, and with our exemplar teams who are demonstrating and refining that this system can actually work. And you'll hear from some of those, including Dominic Cadlake today. We're also developing the tools, and Angela Jones with others has been part of a national initiative, for example, to drive consumer and community involvement. So there's now a plethora of free resources defining stakeholder and community engagement, training people online how to do it, providing support staff to enable them, and actually working with them to make sure they can engage stakeholders right from the outset, rather than just telling them to do it. So there's been, again, years invested in that stakeholder engagement processes. We've been doing a great deal of work around identifying priorities, formal processes, assisting with experience measures and outcome measures, and working with many groups at the university who are experts in this, but also using multiple tools that we will partner with our particular clinical groups or organisations to help them do. In fact, our community groups are now coming to us to help them do it as well. When we come to research from evidence, clearly that's important about making sure people can access the evidence from systematic reviews, from guidelines, making sure they're as closely integrated and accessible in clinical care as possible. We're working with partnerships such as the National Cochrane Group, and actually developing tools and training to ensure that clinicians and quality improvers and other stakeholders are aware of, and that we make this information as embedded as possible in routine care. And we've been partnering with groups in the UK who've actually managed to do this in a systematic way embedded in care. In the data space, and you'll have some really good examples of discussions around this today, clearly we need quality, timely, harmonised, meaningful, actionable data. Simple sentence, you all appreciate that's very difficult to achieve, but there are a number of really big activities, including some led by Melbourne Academic Centre for Health and Dougie Boyle, that are focusing on doing that at a national level. Some work with the Australian Data Research Commons and many other groups active in this as well as ourselves. Important to take data not only from healthcare, but from health-related areas. incorporating those patient-reported measures, and making sure we align with safe and fair principles and privacy requirements. Again, we've been doing a lot of work around this that we don't have time to go into detail, but it's all available on the website. Sydney Health Partners has developed data sharing agreements and principles that all of their partners have signed up to do things in a consistent way. Many of you will know in a project, if you want data access, it can take 18 months and half your research budget to get people to sign on to share their data. We're starting to cut through those at a system level, and indeed Monash Partners has taken that Sydney Health Partners agreement and extended it to identified data, and it's been endorsed by our executive and COOs, and is actually now being implemented across our different partners. So those sorts of things can cut down so much of the places where we get stuck in this area. A lot of work in different areas going on in data harmonisation, quite sophisticated work in big data analytics, and again there are many national collaborations around this, including machine learning and artificial intelligence, and we are bringing all of those building blocks into the learning health system, so clinicians and researchers going on this evidence-based learning health system process can access those things and can move through the system without getting stuck in the hamster wheels that we all do. And obviously that involves bringing in technology and infrastructure. From the Monash perspective, we now have the largely unique opportunity for the massive data platform that's run, that actually all of the NHS in the UK's data is put on that system, and it's a secure, safe, accessible platform. So basically with data governance, people are given the key after ethics or governance approval to go in, access and analyse data, much like we do as clinicians when we remotely access the electronic medical records from home. We can't take anything out of that system, but we can go in, look and modify and then leave.
Sorry, I didn't.
These platforms are the same in doing exactly that. They allow people data access and use, but they don't ever require that data to be physically shared and then passed on with concerns about risk. And there's a number of AI projects, including funded by the MRFF, where we have our health services and our partners and primary care and others actually implementing AI technology, again, technology that's being implemented and partnered with the UK is an example, implementing that into our health systems that will help people when they want to do this sort of work. In terms of benchmarking, we've been doing a lot of work around transparency and equity for service adjustments, making sure we can get real-time visualization of data and being able to measure that. You can imagine that adjustment, benchmarking, dashboards, visualization, every single health service, every single group can develop their own, but a lot of these have core commonalities. And so we've invested quite a bit of work and about to release a report on what the key principles of data visualization are, what is accessible, for example, in maternity care, in stroke, in other areas, and how people can work together to create these platforms that help you as you want to go on your individual projects. In terms of implementation, really important. This is done really poorly in Australia, and ourselves and others have actually demonstrated, including Jeffrey Braithwaite, that in general, almost none of our healthcare improvement initiatives in this country are sustained and scaled. And there's again a plethora of data around how we need to do this much better. But taking that data and that benchmarking into practice is probably the biggest gap, and it's a gap that's prioritised by the NHMRC. It's clear we need leadership, we need rigorous methodology here, and we need to be able to have a workforce that are capable of this. We've brought in the consolidated framework for implementation research, and nationally are working across these centres around how we're going to train a workforce and support them embedded in healthcare to be able to implement. And then finally, how we do that healthcare improvement piece. Again, this is our quality improvement, our clinical teams, people at the coalface. How do we bring all of this together to support them to make a difference that's maintained and scaled? And there's again a large body of work there. Ultimately, all of those components come together so we can create a measurement of impact. We need to be able to demonstrate evidence of progress against the priorities that were set with the stakeholders in that first quadrant, against best practice evidence and research, which was generated in the second quadrant, using that data and benchmarking, taking practice to data and data to knowledge from the third quadrant, again, where we usually stop, and then taking that to actually evidence of improved health outcomes, not just at the individual, but at the population level, for example, reducing variation in care. And we're now starting to see some really good examples of that with particular projects that are using this type of approach. And then ultimately we would have the opportunity to have increased provision of value-based healthcare, which gives us better health outcomes through those processes. So in essence, this is conceptual. You know, people may draw this differently. They may bring in different specific frameworks. But what is clear from the evidence and from the co-development process is that if you don't bring all of these components in, you're likely not to effectively drive change. And without going into detail, these are all broken down in more detail and with more information, as I mentioned, on the website. So just to give you a brief insight before we go on to some of the examples and the presentations we'll have today, we're doing quite a bit of work in maternity care. There's some really good examples of stroke that Dominique will give you outlined here. But essentially that maternity care is a really easy example because it's one where we collect and actually already share nationally quite a lot of data about routine care. The process here that's going on now is about engaging the key stakeholders, developing the experience and outcome measures and setting the priorities, and that's underway. Bringing in the best practice from evidence-based guidelines and randomised controlled trials, often not linked into maternity improvement initiatives. Actually setting up a national data system, and there's a really good system already that collects 86% of maternity data and has been doing beautiful benchmarking for a long time. But they don't have the systems to share their data or to provide access or to allow researchers to use it because of risk. And they've shown over 10 years really significant deteriorations in some outcomes, but they haven't been able to implement. So that partner is now coming in to partner around how we can then take that through to implementation, and they're being provided with implementation expertise, capacity building, coaching to look at taking that through and delivering. And you'll hear a beautiful example about that on stroke shortly. And so the only final thing I'd say is you can't just create a framework like this and expect it to be implemented. And I don't want you to go into depth about this here, but when you implement, and these are the 5 domains of the framework, the consolidated framework for implementation, there are 5 core areas you need to think about. And we're considering all of those when we're actually implementing the system and then the projects that will sit on top of it. So we're looking at the actual interventions and their complexity, the outer setting, especially policymakers. As we mentioned, 3 state jurisdictions have already endorsed implementation of a learning health system approach. The inner setting, so that's our organisational CEOs, making sure that they're engaged and they're building the culture of their organisations and the readiness. Then the individuals, bringing our researchers to the table so they know it's not just about research. Bringing our consumers to the table so they have a lead role, bringing our clinicians to the table so they know they can do this, and our quality improvement colleagues. And then finally, all the processes we have to use to get this implemented. This may sound a bit overwhelming and complicated, but it's all underway. And when you start to look at some of the projects and examples that are presented here, it's building on all of this. But without the system, all of us will continue to have to meet the barriers at every one of these levels with every single project. So just finally, the partners that we're working with are Brisbane Time Health Partners in Queensland as another research translation centre, Health Translation South Australia and Sydney Health Partners, Western Australian Health Translation Network and Melbourne Academic Centre for Health. We're working with the Victorian Government, who's funded some work in implementing this across ourselves, and Melbourne Academic Centre for Health and Western Alliance, which is the regional centre in Australia. We're also working with Queensland Health and through Claire, with King's College London, Health Data Research UK is also setting up a learning health system, and with multiple US agencies who've reached out to us around this work. We have multiple projects that are actually underway in implementation. I've just mentioned a few there. And we have about, I would say about $25 million worth of funding proposals in at the moment to build on and to drive this through areas such as lung cancer, other forms of cancer, diabetes, dementia, maternity care, emergency care. And alongside those projects, we've got significant MRFF and Academic Health Science Centre and partner funding to improve each one of those areas, consumer and stakeholder engagement, working with Cochrane and others to optimise evidence, all those different data components, and then bringing in that final implementation. And there's some of the literature you may wish to refer to. All of that, again, is on the website. So what I hope to be able to do here was take you on a journey from the concept of data hubs for research embedded in healthcare through how we've got to the framework and components for a learning health system, and then how we're actually starting to implement that at a systems level. And now we're going to have some examples of other experts who started to work on that learning health system and their slightly different approaches, which is terrific, which we're all collaborating on, and then some tangible examples. And then we'll have time for questions. Thank you. Thanks, Andrew, for the comment.
Thanks, Alina. Great overview of all of the work that's been done. It's my great pleasure now to introduce Associate Professor Claire Sullivan. Claire leads the Queensland Digital Health Research Network at the Centre for Health Services Research within the University of Queensland. She's widely published in clinical informatics and serves on several national advisory boards for digital health. Today, Claire will be presenting on the Queensland Learning Health System approach and implementation plans. Over to you. Thanks, Claire.
Oh, thank you very much, Angela, and just conscious of the time. So this is going to be a very high level overview of what's going on in 7 minutes, but we'll do our best. And I think if there's time at the end, we're happy to take some questions. Before I start, I would like to acknowledge the traditional owners of the many lands upon which we're meeting today and pay my respects to elders past, present and emerging. So I guess really my interest in a learning healthcare system was born when I asked myself if I knew I was doing a good job as an endocrinologist. And it was a bit sobering when I realised that actually I didn't know, that there was no routine monitoring of the outcomes of the patients I cared for. And I actually didn't know if what I was doing was making a difference to the lives of those who entrusted me with their care. So that really sent me off on a career which I have largely devoted to trying to collect information around consumers and their outcomes in our healthcare system, and trying to use that to enable everybody to do a slightly better job at work today than they did yesterday. And to me, that's what a learning healthcare system is about, where we learn from what we did yesterday and we do better today. So in the next 7 minutes or so, I will talk you through how we're actually implementing that in Queensland. There has been significant investment in this concept, and we're starting to see digital health being the convergence of research and practice to enable better outcomes. So I really like this framework, and I guess a lot of what I'm talking about is in quadrant 3. The evidence quadrant. And to me, we can talk all we like, but unless we actually have the evidence and the data, we will not be effective. So we're really starting to focus our energy there in order to build momentum for culture change and for ongoing investment. To give everyone a little bit of context, and particularly my friends elsewhere around the country, we have a very large single EMR in Queensland, which spans 1,600 kilometres from Cairns in the north all the way down to the Gold Coast. Now, what this does is it gives us an incredible linked data set where it doesn't matter where the consumer touches this system, every single data point is recorded and centralised around that consumer. So that really is, I guess, a very powerful tool to underpin a learning healthcare system. And I am very excited to say that with the addition of the latest digital hospital in Metro North, roughly 70% of all public healthcare, both inpatient and outpatient, is delivered via this platform.
Claire, can I interrupt you for 1 second? Your slides are not progressing.
That's
just
okay.
to check, are you on the slideshow?
Yeah, can you see that?
We can see them down the left and we can see the one slide in the centre, but they don't appear to be progressing.
Oh, right. Okay, let me try that again. Sorry.
Sorry to interrupt you.
No, that's okay. Let me try again. Can you see that?
That appears to be working, yes.
Yeah, okay. So I would just like to acknowledge, although I'm up here doing the talking, that this has been a massive group of people, and I won't go through all of their names, but I also would like to acknowledge the support of BDHP and MRFF in the work that you're seeing today, and just to acknowledge that it truly is a team effort, although I'm up here doing the talking. I head up the University of Queensland Digital Health Research Network, and what this is it's a group based now at the University of Queensland, which is truly transdisciplinary. So obviously it's clinically led, but we have some incredibly clever computer scientists, we have business, economics, law, we have psychology, and we have a whole host of different clinical disciplines all feeding into the idea of a learning healthcare system. And the vision really here in Queensland is that we have a smart healthcare system where all data entered during an episode of patient care is reused to improve the care of subsequent consumers. And I think it can be quite tempting to get lost in the technology and the fancy data. So we're forever forcing ourselves back to the quadruple aim. What are we trying to achieve? Actually, it's not a learning healthcare system, that's just a tool. Actually, what we're trying to do is better outcomes, better clinician experience, lower costs, and improved patient experience. And so it really is important to keep pulling ourselves back to this balanced aim and not necessarily get lost in the technology or the processes themselves. We're following a very graded approach to this, where the first horizon is actually building out those digital foundations. So digital workflows that allow collection of the data. Without this, we can't learn. The second horizon is taking the data out and starting to present it back to clinicians and system managers to understand system performance. And then the third is using that data and those insights to create new and innovative models of care. So the problem we have in the research sphere is that our scientists aren't necessarily connected to this infrastructure or this data. And our scientists, as Helena alluded to, are often creating duplicate information collections to answer research questions. And you might say, what's wrong with that? And part of me says absolutely nothing, and we need to continue. However, we do know that sometimes those questions may not be particularly relevant or impactful. It's expensive to maintain siloed information collections. It's incomplete, and the collections are often centered around a person or a disease. So how do we approach that? Well, I think actually centering the data around a consumer rather than a person, a doctor, a place, or a disease. And what we've done for that is to actually start to dedicate funded operational resources to execute research data requests. These are actually housed within the Queensland Health governance and infrastructure, and we're able to provide graded response to research requests to feed into a learning research system to allow research and practice to meet. So this is the Smart Hub, if you like, and this is really the foundation of where we will start to launch our learning healthcare system. And it really is a closed loop. And I guess the endocrinologist in me loves that. But we have an EMR, we take the data out, we analyse it, we put the support for decisions back into the clinicians at the point where they're using the EMR. So the same place that collects the data then provides them with decision support. And using that decision support, we help them to change the way that they care for consumers. And of course, that outcome is recorded again. So I'm not going to talk too much about an EMR. Most people on the call will have seen the detailed, rich type of EMR that we're talking about. But I guess importantly, it's centered around a consumer and not around an HHS. And I think that has been really important in order to build up that enormous data set. For those of you who've tried to extract routinely collected data, particularly complex clinical data, it is incredibly difficult. And we have here in Queensland developed Quiet. And I would like to acknowledge the computer scientists at University of Queensland, Guido Zacon and Anton van der Vet, who really did all the hard work here. I don't have time to go into it in detail, but what you will see is that this allows defined definitions, metadata, and harmonisation to occur so that anybody can access the same items wherever they are. Not only can you access structured individual elements, there's also the capability within this tool to build out cohorts. We also are now starting to build computed elements and have quite a sophisticated search strategy so that you can actually start to build up unstructured data searches as well, which we are then integrating into our AI sandpit. This will allow us to be able to move from the descriptive analytics that we're currently displaying to predictive analytics, and of course, eventually, prescriptive analytics. No point just having the data unless you know what to do with it. And that really is all about our analytic capability. And I'll show the diagram here today and obviously answer some questions around it. But this is really, I guess, important to understand the difficulties in analysing real-time data versus retrospective data sets. So if you've got the data and you've analysed it and now you have some ability to provide insights back to clinicians, how do you do it? And as Helena alluded to earlier, publishing a paper isn't the end point for me. So how do you engineer it back into workflow? I won't spend a lot of time talking about this, only to show you some examples. So here is some decision support which we've built in Queensland, and this is aggregated data coming out every 15 minutes, which allows clinicians to understand how many consumers in real time have blood sugars that are high or low and resource that up appropriately. We can also do decision support for individual patients where we actually put pop-ups into the workflow to give decision support at the time of decision during the care. But all of this is pointless unless we change a process. And this is one of the hardest things to do. And I guess we're starting to develop a sophisticated understanding around implementation science in terms of this is not a technical change as you might change a drug prescription or an operation. This is an adaptive change where we're asking clinicians to end past practices and acquire new ones. And this does demand new organisational ways of working, which is challenging in an already overburdened workforce. So I'm going to stop there. I guess just to remind everybody, the reason we're doing this is not the cool tech. It is to be able to use, I guess, the technology and the data and the process change to achieve the quadruple aim of healthcare via a learning healthcare system, but importantly, to allow our resources to be allocated appropriately so that our most vulnerable consumers get the care that they need. Thanks.
Thank you, Claire. And I did say to Claire, there must be something about endocrinologists and healthcare. Both of us are endocrinologists. That's brilliant. Thank you. And just one thing for everyone to understand, which is really important, is that Claire has the great fortune, but has been able to do fantastic work based on the fact that they have a centralised data repository in Queensland, which is a really major advantage. So I'm sure we're going to follow in your footsteps in many ways. Sorry, over to you, Angela.
Thanks so much, Claire. Thanks, Helena. It's my great pleasure now to introduce our next speaker, Professor Wendy Chapman. Wendy is the Associate Dean of Digital Health and Informatics at the University of Melbourne, as well as the Director of the new Centre for Digital Transformation of Health. Wendy's interests include biomedical informatics, natural language processing, knowledge representation, and application of informatics to clinical care and research. Today, Wendy's going to be speaking about some of the learning healthcare system approaches progressing under the Melbourne Academic Centre for Health. Welcome, Wendy, and over to you.
Thank you. It's such a pleasure to be here. And I think one of the things that you're going to find interesting in these presentations is that we're all working under the same model of the learning health system, but we might call it something, a little bit different, and we're using different ways to operationalize it. And so I think the principles in the diagram that Helena showed underlie everything that we do, but how we do it depends on what we're trying to do specifically and the context that we're in. All right, so at the University of Melbourne, we are calling it a learning healthcare system because we really are focusing on the delivery of healthcare when patients interact with the system. We might change that in the future. We've had a lot of arguments about it. But I want to first introduce you to Joanne Mansky-Nankervis. And this is work done with other people with Joanne, Dougie Boyle, Lena Sanchi, starting with Jane Gunn in the Department of General Practice at University of Melbourne. And they have been working towards a learning healthcare system for many years and have a lot of things in place to support that. If you start at the top right in the orange, they've created a research and education network of general practices to help bring those stakeholders together and prioritize and test things out. They have developed a data set from general practice data that they use for research, but also to drive care. And they have a dashboard called Future Health Today that is used to be able to communicate that information and implement these interventions with the clinicians. So they have a lot, other things going on that are on the slide that fit onto this diagram. So really, here's an example of how they're taking data and they're learning knowledge from it. They're taking that knowledge and they're applying it into practice. And then in practice, they're generating data from what they do. So example of a 58-year-old man who has type 2 diabetes and a history of cardiovascular disease. And a practice nurse can conduct a practice level audit using the Future Health Today dashboard. And this is collaboration with Western Health. And it has an algorithm that looks at the patient's risk factors and create a list of patients who should be, recalled for GP review. So the patient receives a recall notice and comes in for the appointment or for a telehealth appointment. And at the point of care, during consultation, then the dashboard, there's a pop-up alert that shows the GP the patient's risk factors and gives recommendations for, in this case, for a kidney health check to be undertaken. So the doctor conducts that check and diagnoses it. That information goes back into the EMR, and the patient is identified as, high risk and given the appropriate treatment. So this is the interface of, the EMR that shows how on the right bottom hand side, you see the information from Future Health Today to help guide that clinician in the visit. And so Future Health Today is a powerful platform to pull data from the GP EMRs and be able to present information for decision support. And this is being tested across the, the research network. So my question in my role is, how do we create similar successes across NAC? And how can we learn from what the Department of GP has done? So this is the model that we're using for the learning healthcare system. And it's a value-driven model where we are trying to improve clinical decisions in order to improve outcomes that matter to patients. We want to leverage data to measure and track those outcomes and to learn what are the best ways to treat patients. And we also want to implement and evaluate innovative models of care so that the right decision is the easy decision. All right, so the way that we're doing this, because we're just starting out of trying to make this a more generic process to support our partners, is number one, to create those partnerships with the health services. So we have co-hired what we're calling clinical informatics translational directors and associates with our health services partners. And that is to really create a strategic alignment to identify pressing problems, bring them to the table in prioritization and build synergies, but also facilitate, these collaborations. The second thing is to really empower more people to do this, because as we visit with our health services partners, the number one thing they say about learning healthcare systems or about digital transformation is, we don't have the workforce to do this. And so we are creating a Learning Health System Academy that we will launch in February. And this will be a project-based fellowship program to help train up and empower clinical champions who can then, use what they learned in their work and continue to grow these types of processes and principles across their health services. And so they will do year-long projects that are co-produced with the health services. They'll work in teams. Our clinical informatics directors will mentor them and will facilitate the interaction with the health services. The university will bring to the table the domain expertise of the many disciplines that are needed to create new innovations and learn from data. And the health services, they have skin in the game because they are sponsoring these clinicians, as well as co-producing projects that they want to implement and evaluate. And so their operational teams and their leadership teams will be involved. The third is, we need to train a lot of people, not just people we can put in these year-long fellowships. And so we're starting with the Applied Learning Healthcare Systems short course that is going to be launched in October. And we'll step through a case study from beginning to end of how do we decide what to work on, and collecting the data and cleaning the data and analyzing it and learning from it, to coming up with an intervention that seems likely to succeed and have impact, to building and validating the intervention, to how do you really take that intervention and go from a pilot to something that's sustainable. And then finally, as we do this, we'll be building infrastructure that we can share and reuse. And so we have three areas that we're working on. One is in the data to knowledge space, is the health intelligence platform. I didn't use very much intelligence when I spelled intelligence there. And that's really the data platform and the environment to help people mine and learn from the data. And the second is the knowledge to practice. And that's the digital health Validitron, which is an innovation pipeline to help develop, validate, and implement innovations in care in a simulated way to help prepare them for real settings. And then finally, the implementation and evaluation service to be able to really demonstrate whether or not these have impact. So we are trying to accelerate the learning health system here by piloting a model that we hope others can replicate, and looking forward to sharing our learnings with everybody.
Angela, over to you.
Thanks, Wendy. Thanks, Helena. It's my great pleasure now to introduce Professor Dominique Cadillac as our next speaker. Dominique is the head of the Translational Public Health Research Division at the Stroke and Ageing Research Group at Monash University. She's an expert in public health research related to stroke and cardiovascular disease. And today, Dominique will be telling us a little bit about stroke as a very interesting learning health system exemplar. Thanks, Dominique. Over to you.
Okay, well, it's been fantastic hearing about all the programs so far. And this is, we did talk earlier about, you know, the focus on a particular disease, and we have got a focus on a particular disease, but through data linkage, we are also able to look at broader aspects and impacts on individuals that are at that consumer level, but that's still a work in progress. So stroke is the leading cause of death and disability, and it is a high volume condition that impacts our ambulance and hospital services, and then later on in the primary care sector. So it touches every type of healthcare delivery system. And the work we've done with the registry in having patient-reported outcome measures and doing data linkage with death registrations every year, and comparing the performance of hospitals and whether they deliver one evidence-based care practice or more compared to none, has really illustrated to us, using these real-world data from our registry that has been established since 2009, the impact of that. And there's a really clear dose-response relationship. So this bottom line here is the hazard, is the survival. If you don't receive any of the evidence-based measures that we record, the next is if you receive at least one, 2 or 3. So there's that clear dose response, and why variation in practice is so important to reduce. And what that translates to within 6 months of a new stroke event is a 70% reduced hazard of death if you get what you're supposed to get when you're in hospital, and an 18-point increase in quality of life. So this really helps spur on our work in reducing variation in practice and making sure we can support clinicians through a data-driven approach to understand what's going on in their sites, to understand how they compare to peer hospitals across a state jurisdiction and nationally. So this is some work I've done with the Australian Commission on Safety and Quality in Healthcare as part of their Better Care Everywhere program that was undertaken last year. And we summarised the learning health system for stroke in Australia according to these the pillars and the continuous quality improvement of. So we're fortunate in stroke that we've spent a lot of time developing clinical guidelines and frameworks. We have a standardised data collection system. We don't have full coverage across the country, and there are different issues that impact that. We have quality improvement activities, and through that we're able to measure improved care, but also the patient outcomes. So really where my role comes in as the data custodian for OSCA is around the use of the data and how it can be applied for the quality improvement activities. And where we've been able to implement our Plan, Do, Study, Act approaches in partnership with the Stroke Foundation, and we work with Monash University and the Florey in the feeding back of that data in different types of formats, whether that's through CEO reports, board reports, individual hospital reports, our annual reports, and we also do public summary reports. But the main way in which we like to support hospitals is by running facilitated workshops with them, getting them to first understand their data and the gaps in their data, then working with them on a structured action plan and a commitment over the next 2 to 3 months of writing that action plan to address their identified barriers to that practice change that they can modify. So we, in effect, I really appreciate the fact that we do need a learning health system academy. I like that idea. I like the fact that we need some mentoring and facilitation so we can empower clinical champions, because we're trying to do this at a micro level within individual hospitals where we have support to deliver this type of program. And wouldn't it be wonderful if there was a better way of teaching these skills and techniques, irrespective of what type of data you're collecting, but bringing that together as a whole so that people had a greater understanding. They're working in the clinical space on the importance of standardized data, but also in interpreting that data and working through a process of how to change and make practice change happen. So we then, can track how well we're doing through the fact that we collect the patient-reported outcomes and we reassess that against their performance. So that's our learning health system in a nutshell. We have to always look at what we're collecting. We have a living guidelines program, so our evidence base does change and sometimes our recommendations. And when you're running a registry, it's always important that we consider what we collect. Is it meaningful to clinicians? And because of that, we've now established a quality improvement committee that has clinician representatives on that to help with some of this decision making as part of our governance. So thank you for listening today.
Thanks, Dominic. And I think the important thing here is that I think when we first touched base around this, we realised that the stroke team were probably the group who were actually implementing the learning health system without necessarily realising they were doing it. So they have really strong stakeholder engagement and are actually building on their prems and proms at the moment. They have the living guideline in the second quadrant, as Dominic's very nicely described. They've got their registry in the third quadrant around data, and their benchmarking systems already set up. And there's a range of really fantastic implementation research studies that Dominic's not able to go into in detail, where they've actually looked at exactly the best way even to implement through different, whether it's funding incentives or education or systems change. So they're actually doing that in an iterative learning health system, and it's a really beautiful example of bringing it all together. And I just want to congratulate Dominic on her work with her team and her perspective. And can I just make one other comment, which I should have done, and Claire did very eloquently, which is to highlight that the work that I outlined there has been contributed to by a great number of people and a great number of partners. And it's really important that I acknowledge Alison Johnson, who's going to speak shortly, as the lead on the Monash Partners platform, and also Joanne Endicott, who was our fellow on developing the learning health system, as well as many others, including committee members and others. So back over to you, Angela.
Great. Thanks, Dominic. Thanks, Alina. Wendy, I believe we're coming back to you now for a brief presentation on some work that's been funded under the Victorian Healthcare Recovery Initiative. And this work is focusing on telehealth and virtual care, underpinned by a learning health system approach. Back to you, Wendy.
Yes, thank you. So this is a project that is funded by the Victorian government under the Victorian Healthcare Recovery Initiative. It is co-led. There are 6 of us that lead this across the 3 different Victorian, what they call ARTICs, NAC, Western Alliance, and Monash Partners. And the focus is virtual care. So what drove the topic for this project is that, integration of care is one of the key challenges facing the healthcare system. And so our aim was to develop a learning system to optimize digital solutions that support integrated models of care, focusing on older adults in Australia. So the question that we started with is, which virtual care activities should the Victorian Department of Health invest in order to scale up and potentially improve care outcomes across Victoria? And how can we use the learning healthcare model to really guide the answer to that question? So following this model, we built into our processes to do co-production, and we have a co-production team that has people from government, community, health services, clinicians, and patients. And that group is setting priorities and gathering evidence. We are synthesizing existing evidence, both from the literature, but also from the health services to see what they are doing in this space and what's working and what's not working. The plan is to do economic modeling and to examine the feasibility of this. So if I go through these and tell you where we're at on it, the first is we synthesizing the existing evidence. And so we did a rapid scan of the literature to look at existing initiatives across Australia and what are the challenges, especially for delivering to older adults, and what are the service gaps. We also had a survey that was given out to all the CEOs of health services, including some aged care facilities and hospitals, and looked at what types of virtual care are you embarking in now. And we identified 6 types of virtual care initiatives, including telehealth. Obviously, everyone had telehealth, but then there were some remote monitoring, virtual ED, and other different types of virtual care. We identified 6 areas that people saw as service gaps that could be filled, and 11 main challenges for implementation of it. So took this information to the co-production group, and they looked through it all, and I was quite surprised in what they came through with. And we had several meetings with them, and they said, we think the most important place for you to look is the virtual ED, that this is a model that could be very promising, and we want to learn more about it. So that is becoming the focus of our work. And what we also learned is that the main barrier that was identified by the health services stakeholders and the co-production group is the information flow across services. And so we will be going out and learning, what's the information that's needed by each stakeholder, where does it come from, and doing technical demonstrations of how you can facilitate that type of data flow. And then doing some economic modeling about, what would be the cost effectiveness if we were to scale up the idea of a virtual ED to be more centrally run, whether it's a group of health services or across the state, versus a service by service model. And then to synthesize existing evidence again, but this time about the effectiveness of existing virtual care initiatives, virtual ED initiatives for prevention of unnecessary presentations among older adults. So this is where we're at on this, and the goal is to create a roadmap for how we might scale up virtual EDs across Victoria and perhaps Australia. And what are the issues? What do we know? What do we need to know? What's in place? How do we get there?
Thanks, Wendy. Really interesting body of work. Great to see it evolving so well.
And actually, Angela, just to add there, even the project itself followed the learning health system model. So even getting to virtual care was a process where we went to stakeholders, very large community survey, engaged with the CEOs, engaged with the department and clinicians, then went through what is the evidence about the greatest impact, then actually where we might be able to measure that data. And so even the projects that emerged, such as virtual care, and the other one is value-based care, there's another one on telehealth and on the impact of COVID on healthcare, all of those projects were actually developed through that process that are following that. And then Wendy's giving you a really good example of that one particular important initiative.
Thanks, Selena. It's my pleasure now to introduce Dr. Anna Marinick from the Monash Partners team. Anna is our Senior Project Manager and Project Lead for a Monash Partners Medical Research Future Fund grant. And this grant is looking toward a national data management platform supporting Australia's learning health system, and through a tool called CogStack. So over to you now, Anna, to tell us a little bit about this project.
Thank you, Angela. So this project really builds on the 2 to 3 years work and investment in the Monash Partners Learning Health System. And as Angela had mentioned earlier, it's being funded through the MRFF program to progress a national data management platform and learning health system. Now, the novel and key piece of digital health technology in the platform that we're trialling for this project is called CogStack, which uses natural language processing to unlock electronic health records. And I will talk a little bit more about CogStack in a moment, but I'm just going to very briefly highlight the opportunity that we're looking to exploit and how it ties into the learning health system, and specifically this data evidence quadrant. So with the huge increase in the amount of health data that's now generated and collected electronically in EHRs, combined with major advances in digital health technologies, this really provides an amazing opportunity to leverage the use of data to drive health improvement and transformation. And we know that the jury is well and truly in that improving the ability to access, understand, analyse and compare high quality health related data to inform clinical decision making is proven to improve health outcomes. Now, a prerequisite to implementing a sustainable learning health system is an infrastructure or data platform which allows access to both real-time and longitudinal patient EHR data. Now, in addition, up to 80% of clinical data, it's unstructured, and Claire talked a little bit about that. So a lot of this data is embedded in, free text clinical narratives. And so that makes technologies like natural language processing, which can essentially tap into those narratives to extract the relevant information, an essential component of implementing a learning health system. So our goal or aim is really to enable a learning health system underpinned by this national data management platform that allows the use of data to create an iteratively learning health system. I also want to flag that this project is indeed a joint collaboration between 12 organisations, the logos of which I have listed here on this slide. So just a little bit about CogStack itself. So CogStack was developed by bioinformatics and health informatics researchers at King's College London in the UK. And as Helena had mentioned in her presentation, this platform has been really successfully deployed and implemented in multiple NHS services in the UK, and its implementation is being scaled across the entire NHS. Here, Monash University have established a really strong collaboration with King's College London to adapt CogStack to the Australian context. Now, CogStack, it's an application framework that allows extraction of information, again, from unstructured data sources. It's open source, it's low cost, and it's really an easily deployable solution that's been designed for healthcare environments. So it's designed for working with EHR databases, really amongst a landscape that's heavily occupied by quite costly proprietary systems. It's important to note that it isn't a single application. So it's actually a combination of multiple component modules or microservices that communicate together to create what's known as the CogStack platform or CogStack ecosystem. So in the CogStack platform, it's comprised of these open source technologies that include things like enterprise search, natural language processing, analytics and visualization technologies, again, to unlock the electronic health record to assist in clinical decision making, as well as research opportunities as well. So what exactly is the motivational driving force behind using these, NLP-based tools like CogStack? So data housed in EHRs, they're often incomplete. They contain really large quantities, up to 80% of unstructured data. They're quite often stored in proprietary systems that are heavily siloed and in multiple different formats. And essentially the challenge is, most of this information, it's just written in a form that's it's really difficult to retrieve and analyze and therefore learn from. So CogStack applies NLP and AI technology that allows you to extract that information regardless of the format. So, whether it's unstructured in PDFs, free text, or, that type of format. So just in the last sort of couple of minutes, I wanted to talk to you a little bit about the centres who are trialling CogStack and share with you their implementation use cases, each of which are in quite different settings. So these three centres are Alfred Health, Peninsula Health and Outcome Health, and they're the first to implement CogStack here in Australia, supported by and developed in conjunction with the Monash University team. So CogStack has been deployed within the IT environments of all three of these health services, which is really exciting. And this includes ongoing, fine tuning of their performance and architecture at each of these sites. But each site is really in a position now to start running data through the pipeline. And I'll just talk to you a little bit about each of the use cases. So Peninsula Health, they're implementing CogStack with use cases that are relevant to aged care, such as dementia, which is often quite poorly documented and can be difficult to identify in very structured EHR records. So the CogStack platform, through the use of NLP algorithms, will identify keywords and phrases within the context of the surrounding medical text that suggests a person may be presenting with signs and symptoms that are consistent with early dementia. Alfred Health's use case is quite different. They're utilising CogStack to identify people that may be appropriate for clinical trial cohort selection. Here, CogStack is also we're hoping to compare CogStack with some tools that Alfred Health also use. So specifically, Cerner EMR tools will be compared with CogStack's open source tools as well. And the third use case is where CogStack is being trialled is at Outcome Health. So they're an organisation that amalgamates primary care data to provide data dashboards and information for GPs and all stakeholders in the sort of that primary care data space. Outcome Health already have their own data management system. However, their aim here is to essentially explore alternatives, and in doing so, compare those current systems with CogStack and its ability to use NLP to again unlock that unstructured data source. So with that, I'm going to wrap up, but happy to take any questions that you may have, and my contact details, I know we'll be supplying those at the end. So do reach out if you have any further queries or would like some more in-depth information. So I'll hand back to Angela. Thank you.
Terrific, Anna. Thank you so much. What we're going to do now is there've been a series of presentations, and I'm going to hand over to Alison Johnson. Alison is the Monash Partners lead for data-driven healthcare improvement, and she also is the senior lead on a national body of work through the Australian Health Research Alliance, which encompasses the 10 NHMRC accredited centres. And Alison now is going to provide us with a little bit of a summary of some of the key themes from our presentations to date. Alison, over to you.
Hi all, and welcome, and thank you for joining us. It's my pleasure to wrap up the presentations for the day. It's very clear that Australia is absolutely not lacking in health-related data, and the challenges of how to utilise that and present that to our clinicians in a way that is useful and can be integrated into their healthcare provision is a real challenge. And the learning health system is an approach that's applicable across a wide range of settings and applications. So our purpose today has been to present and discuss how to improve health outcomes across our community through data-driven innovation and care. And you've seen several models of the learning health system, and all of them have that common link, that aim to improve the use of health data to improve health outcomes for our patients. One, right back in 2019, when we were looking at how we might go about improving the use of health data in healthcare settings, we carried out the 26 qualitative interviews with stakeholders across our partner organisations, and I went looking through those interviews for a quote that I thought might resonate, and this one I understand the fellow has since published, but I really felt that it captured quite a lot of what we were trying to address, and that is don't collect data just because you can understand why and how it will be collected. Those who generate the data should be able to use the data. There's no secondary use of data. All uses of data are valid. All data comes with a social context. Ignore this at your peril. This data is generated by workflow processes and can also be destroyed by workflow processes. Remember, big data is nothing more than lots and lots of little data. An algorithm can never represent reality. Get as close to the source of the data as you can. Minimise data rehandling and data processing. Linked data is actually patient-centred data, and no one should own data. It should be free and mobile. So the key points we've heard today are about our learning health system and how it is a conceptual framework. It provides structure and guidance to include all aspects that are necessary for successful and sustainable approaches to the use of health data to improve health outcomes. And the Monash Partners Learning Health System is based upon a rigorous and evidence-based approach. From a personal perspective, I often listen to the wonderfully visionary presentations that Helena provides and think, if I were a clinician still, would this seem over my head? And yet when you look at the learning health system that we've presented today, it's as applicable to a small service looking at improving the health outcomes for their patients as it is for these large multi-million-dollar funded projects. So if you go to our website, you can download the tools to inform yourself on how you might apply it to your setting. And of course, we're always here to see whether there's things we can do to assist if there are issues you wish to discuss. So there is interest across all of Australia in this approach. You've heard of a presentation from Claire in Queensland, Wendy in another Artex, so based at Melbourne University, MAC. We've got interest in Brisbane, New South Wales and South Australia in using a common approach to improving the use of data in health outcomes. So it's a very exciting time for us all. It's time to try it out and not just attend events. Download the information from our website and reach out if you'd like input from our team. I'd like to acknowledge and thank all of our speakers and panel members for today, and I'll hand over now to Angela to introduce the panel section of our session today.
Thanks, Alison, for a great summary. I'm actually going to hand over to Helena. Our presenters today have generously agreed to stay with us and respond to questions that have come through the chat and the Q&A. And I'm going to hand over to Helena to facilitate that discussion.
Great, thank you very much. I'm just going to work through a series of questions and also the ones that you've actually put in, and thank you very much for using the Q&A and for prioritising those. We'll also include some additional questions that were actually sent in beforehand. So what I might just start with one because I've got a note here that Claire would also like to come into that. So we've had a question from Andrew Pullington about cost effectiveness and value-based healthcare. And Denise O'Connor, and I'll put the contact in there, is actually working on a value-based healthcare initiative using the learning health system at the moment. But yes, people are linking patient-level data and costing data and are using this. And Dominic might want to make a comment, and Claire also. But if we can just perhaps address the broader question of value-based healthcare and using the learning health system to address this. And at context for that, Andrew, obviously, once you start with patient-reported outcome measures and patient experience measures, as well as measures around value-based care, and then you look at the best practice evidence, variation, and the cost measures that you're talking about, which come from that really frontline care provision, and then implementing change and whether that will change the value-based healthcare algorithm, it's a really good system to do that. So, Claire, did you want to make your comment first, and then I'll hand over to Dominic?
Yeah, look, thank you. And I think this is one of the challenges. So everything that I've described this afternoon is hideously expensive. And as you all know, funding in healthcare is tied to activity. So if I'm saying we need, 20 people to run the systems, data analysts, how do we convince our system managers that this is worthwhile expenditure, particularly when it's expenditure that's not linked to activity? So we have been doing some work, and I just want to acknowledge Tracy Comans and Kim Hong Nguyen, who have been doing some work thinking about how we can define value in a learning healthcare system, predominantly using the quadruple aim. So remember that value is not just about cost or about patients, it's also about the quality of care and also clinician experience. So to define value broadly using that expanded quadruple aim, and then to start to actually put some cost benefits analysis around it. And this is tricky because the quadrant around efficiency is well costed up. There's a unit price for everything. You know, there's the national efficient price is well known. However, the other quadrants, consumer experience, clinician experience, and care quality did not routinely have dollar values linked to them. And so part of this work, supported by the Digital Health CRC, is to actually start to ascribe costs to values across the quadruple aim and start to cost it up in a language that speaks to funders and speaks to system managers. So we all know that it's valuable to reduce adverse events, but to those that are doing the sums, it's, you know, there's perverse incentives around actually getting funded for more complex care episodes. So I think it is an acknowledgement that value is across all components of the quadruple aim, and that we actually need to cost up across that quadruple aim in order for us to make learning a valuable part of the healthcare system, not just in the efficiency quadrant, but also in the quality quadrant, clinician experience and consumer experience. So great question, Andrew.
And just on that, I think learning from some of our collaborators in King's, one of the orthopaedic surgeons who developed some of these platforms, said the first thing he did was he had to convince his CEOs to invest in a system and to give him the infrastructure you're talking about, Claire. And so the first thing he did was spend 3 hours in an office looking at the DRG, or the codes that actually generate their income. And in 3 hours, generated a multi-million-pound windfall for the organisation, and not only in that one setting of looking at DRGs using artificial intelligence, because we often know people don't necessarily describe diagnoses well enough, but I actually started to eat into the massive army of coders that we have sitting within each health service, and then we pay external organisations to recode in case there's more money in there. So when you start to do things like that, and in fact that's some of the work we're now doing, to be able to demonstrate just immediate value in savings. Whilst that's not ideal about better patient outcomes, it is actually a pragmatic way to then get substantial investment. And also, just to build on what you're saying, Claire, we've actually just finished a major health economic analysis this morning around implementing an evidence-based strategy into maternity care that would save $1 billion a year to the same to the same funder, which is basically our hospitals, for something that gets implemented in pregnancy and reduces pregnancy complications. So it's very easy to do this, and I would suggest it's best done on a learning health system for the quadruple aim, which is what Claire's highlighted, because you can bring in more than just cost, you can bring in those outcomes that the funders think are really important. Wendy and the other panel members, did you have anything else you wish to add onto that value-based? No, okay. And the only other thing is just to highlight that Denise O'Connor is I think I'll put her email address there, is actually the international lead in, beg your pardon, I'll come to you, Dominic, in audit and feedback, and has done a lot of work on value-based care. And we are working with the jurisdictions about how to use the learning health system to drive this. Dominic, over to you, since you have quite a health economic background. So.
Yeah, I just wanted to comment though, like although clinical costing data is available from hospitals, there are some pitfalls with it. We have linked the data for our registry, and we're starting to look at, you know, how we can conceptualise return on investment from our registry and improving access to evidence-based care. But one of the issues is that you can use it to unpack within a disease condition or different types of patients where the resources are allocated. So whether you're spending more on allied health or nursing or on diagnostic services and things like that. You know, we've specifically looked at patients with stroke that have aphasia compared to those without, and what the differentials are. The problem is with value-based care, it's not just what happens in that one little pocket of the experience of the patient journey. It's, did they bring take an ambulance or not? Did they require transfers? What happens to them out in the community? And we lack that information across the whole system. So I think that having a way of capturing not just clinical costing data from within hospitals, which is a very small sliver of what you can look at, it's actually looking at resource utilisation across a patient care journey and then being able to add costs to that. But that requires people with expertise in health economics to help guide some of that, to then look at the broader returns on investment or value-based care that comes from delivery of an optimal pathway for that person compared to one that might have been suboptimal, which is what we're talking about, and that they themselves had a good experience.
And the other thing too, just to highlight, we've developed in our learning health system implementation, we've developed those platforms that I'm talking about in all the quadrants, and one of them is actually integrating health economics. And any health economist will tell you, including the one that works with us and is embedded here, that you need to think about that health economic issue right from every quadrant. You can't just bring people in at the end, so that all those issues that Dominic has highlighted are integrated, and indeed actually making sure that the health economic principles go through every one of those quadrants is really important, and is actually part of that implementation quadrant, which I didn't emphasise, but is really important. I might actually defer the next question, which was on the consumer and community involvement. Thank you for the question. It was around how we, and it's a very important question because it highlights you don't just bring your consumers, who are both the funders and the beneficiaries of healthcare in Australia, and the funders and the beneficiaries of research. And yet they have actually very little role in either of those, and a lot of it is tokenistic. And it's usually well intended, but it's hard to know how to do it. And in working with our stakeholders, and Angela Jones has championed this and worked with the national centres in ARA, including MAC and other centres, around how we meaningfully engage consumers, and we're learning all the time. And we have international thought partners who we work with in the UK and Canada, who've been guiding us in this journey. But the thing about this is it's about co-production. So co-design, you can have people involved at the front, so you understand the question and the problem from their perspective, and they develop prems and proms with you and priorities, but you can't just leave them behind, because actually they need to go on the whole journey with you and hold you accountable and assist and co-produce. So really be integrally involved at every step of the way. And I've put the link in the Q&A section there, and I'll put it just in the chat as well, for you to be able to access those resources, which Monash Partners led on behalf of all the centres nationally funded by the MRFF. But Angela, I'll hand over to you to answer that question of the importance and how you keep those consumers involved at every step.
Thanks, Helena. What we've focused on doing under the Monash Partners Consumer and Community Involvement Platform over the last probably 2.5 years is really building capacity for genuine, meaningful engagement with consumers at all stages throughout the research journey. And what we realised was that there was a real need for people to be able to access the best resources. And so what's on the Monash Partners website is a curated set of some of the best work that's been done, not only here but internationally in the US and the UK. The other part of our learning is that there's a lot of interest in doing this work, but most people struggle with where do I start and what do I do? And so we offer practical advice and support to research groups across our network, and an event series which runs as a seminar once a month around some of the practical, tangible things and people speaking about their experience of doing this. We've spent a year developing a proposal for a national knowledge hub in consumer and community involvement, and what emerged from the process of developing that was that what people are most looking for is to connect with others who are doing this work and learn from each other. And so we hope that the knowledge hub will definitely strengthen that as well. Definitely there is it's resource intensive in terms of establishing, building and maintaining involvement of consumers. It's incredibly important. We're also looking at how we might be able to do that at a partnership level. At the moment, various research groups across our network and health services all have consumer advisory groups, and so we're looking at what the optimal way to do that is and how we might be able to do that at a partnership approach rather than in individual organisational silos. Thanks, Helena.
Thanks, Angela. I don't know if anyone else wants to specifically comment there. Jump in if you do. In fact, Rob Sterling's comment is about that really critical need to move from the benchmarking of data through to implementation and how consumers are involved in that. And that's critically important, Rob. In fact, it's probably the biggest barrier we've been on this journey. So because I run a centre for implementation, and I have an NHMRC fellowship, but my key focus area is actually on implementation. And I've spent some time in the UK, Canada, and indeed in Asia and the US around this. And it is something we are really poor at in Australia. We simply don't have the capability which has been invested in internationally around implementation. And we naively think if we've got the data and feedback the prompts, or if we've got the guidelines, God forbid, or we've got the RCT, that it will change. And it's actually that there's a full process to implementation. And once people understand that it's not a linear process, but it's got very tangible, understandable steps that clinicians understand really well. Because the thing about clinicians is every patient we see is never the same. It's never a linear process. Every patient is dynamic, things change. Clinicians are very comfortable with complexity and change. And indeed, implementation is exactly that. It's messy, it's the antithesis of a randomized controlled trial, but there are principles and processes that definitely support and enable implementation. I did also note in the chat that in that space, in the quadrant for Monash Partners, we have co-developed with, we've consulted with the jurisdictions, including the Victorian Department of Health, but with experts internationally, nationally and elsewhere, and actually looked at how we build implementation capability. And there is a series of strategies to do that. There's a lot of information on the website. There's free tools to be able to do that. There's also 2-day masterclasses, and then a program like what Wendy described for the LHS, but actually focused entirely on implementation that will bring people in at the start of a year, coach them, so train them and then coach them and create a network in their projects over the year, and then actually then support them to create capability within the organisations. And that's leveraging up a model that's successful internationally, but is evidence-based and co-produced. So again, if you want information on that, let us know. But there is ways to do that. We're just not good at it in Australia. Can I come back? And I'm going to link in Tim Shaw here, who I hope now can speak to you as well, because there was a question here that was particularly relevant about the streamlining of different strategies around, let me find this question, beg your pardon. It was about data. How do we do this in a seamless way with all the different applications that are out there? And they gave the example of Health Track, and there are lots of other. I just want to give you a really quick insight and hand over to Tim, because he's got insights from Digital Health CRC, which is part of the MRFF project that Monash Partners is leading with many of the other centres at the moment. And indeed, Tim's leading this work. Is we're doing scoping about what's out there, what's being implemented, what's being used. Out of that, not only will we come up with a compendium of what's there, but actually some of the key principles that people should think about when they're going to choose and implement tools. And we're working directly with policymakers, and this is a priority of Greg Hunt's, to try and limit the extensive explosion of different tools, especially commercial tools in the country, and try and sit with a suite of the most effective tools that can be implemented on a more national level. Tim, can I hand over to you to explore that a bit further?
Sorry, Helena. Yeah. So I guess I couldn't quite find the question, but I think you're talking about how do we move this forward systematically and link the different pieces together with the reviews that are going on. So I may describe a little bit about what we're doing in that. So certainly in New South Wales, we're looking at reviewing kind of all the different applications that are starting to bring clinical analytics and decision support in that kind of learning health system context together. This is through the Agency for Clinical Innovation with Jean Fred. And because I think one of the challenges I see as I kind of looked across the whole system at the moment is there's lots of pockets of innovation going forward. I think Queensland, through the great work that Claire's doing, is kind of moving ahead, and they've got that huge advantage you said of the single instance of Cerner and the integrated IEMR, which just you can just see the power that starts to provide. But what we're kind of starting to look at is how do you kind of start to operationalize this at a much larger scale. And what I'm seeing in most of the jurisdictions is a number of tensions, particularly tensions potentially between kind of organisational innovation, where you have at the moment, I think a lot of that innovation around learning health systems is coming from that organisational level, because the data tends to reside at that level, and with more of a centralist approach, say at a jurisdictional level, and who, you know, we're almost still at that point about who builds the roads and the traffic lights and the kind of signposts, and who's building the cars that kind of run on it in terms of the actual application of the digital tools that we develop. So I think that's the kind of point we're at the moment, and it's how we bring that together. So in New South Wales, we're certainly surveying all those type of applications and different innovations, and then starting to bring them together to say what's the best of these, how do these get applied. With the CogStat work, I guess that's lifting that to another level, to start to look at not just you know, kind of basic analytics, but more advanced kind of application and NLP. So where is that actually being applied into actual practice and application? Because then I think it'll be really good nationally, and I think initiatives like yours can help kind of float all the boats in a way, so that we can start to kind of learn from each other and integrate this. And then, you know, ideally, I'd really like to start to think that we can start to have some national approaches, national programs. So we funded the clinical data analytic platform through the Digital Health CRC in the early days of COVID, to say, can we bring kind of COVID data together nationally in real time? And it's been enormously difficult. It's been some really nice outputs of the project, including a whole part of work around governance, but, you know, we just can't do that. So I hope that these kind of initiatives can help us start to sort things out, so we can do them in an organised way jurisdictionally, and then start to come together to do it nationally.
Great, thanks, Tim. And Tim's been a really important contributor into that national initiative, and was also on that original work we did around prioritising the learning health system. So we've got a couple of really good comments from Ken around CCI, and the fact that consumers can handle complexity as well. And I have to say that's a very insightful comment. The reality is consumers don't just have heart disease and don't just have particular life stages. They, you know, classic example, maternity, they go through preconception, pregnancy, postpartum, childhood, motherhood, fatherhood, right on to older age, and yet our system is very poorly integrated around actually caring for consumers in their journey, and with their multiple social determinants and influences on health and their multiple conditions. And indeed, I think they're very well placed for complexity. So thank you for that, Ken. There was also a comment about rare diseases. I will hand over to Claire, and then I'll make a comment on that as well. Claire.
Look, I just wanted to, I guess, follow up with that question and Tim's great answer about data. And one thing that is emerging, I guess, is Tim's point about it's impossible to get all the data together nationally. Right. And one thing that we've been working on is actually federated learning, where instead of acquiring the data ourselves into a pot, the data stays in its local jurisdiction, and we send the algorithm to the data. And this is something we're working on at the moment with Barcelona and Emory, where the data stays in the jurisdiction subject to local ethics and governance. It's harmonised locally, and we're working using OMOP to do that. And then rather than trying to put all the data together to learn, instead we send the algorithms to the data and the jurisdictions. And Tim, you know, I'm sure you're aware of this, but that gets around a lot of those data, governance, provenance, sovereignty issues. And in my view, with your health track question, it may not be around putting all the data together. Instead, it might be around establishing federated learning capability. And, you know, we're starting to do that now, and keeping the data where it is, got its provenance and its governance and its sovereignty, but instead taking the smarts to the data. So I think there are innovative ways to get around this that don't necessarily require us to put it all in a single data container, but instead to take the analysis to the data, if you will.
And I agree, Claire. I do say though that it is nice to have a single IEMR where at least you've got harmonised data. So I agree to send the algorithms out into federated system is ideal, but then there's obviously a whole pile of challenges with that as well. But I agree.
Yeah. So not taken away from the single instance, but I can see that in the future we are never going to be able to negotiate data export and import in the way that we would like. So we are going to have to be flexible in our approaches across jurisdictional borders, and federated learning is going to be, I suspect, one of those.
Actually, ironically, in the CDAP project, the Clinical Data Analytic Platform, we are actually doing analytics on European data sets that are being used, and we're sending the algorithms to Europe, and they're being run on the data there. It's just a slightly more tortuous route. It's just hard. It's harder work.
Harder work, agreed. Yeah.
Great, thank you. So just a couple of other, I'm just trying to keep up with multiple coordination of things here. In terms of the other question that's been about integrated care and the client journey. So in fact, this is probably one of the most exciting things about data, is actually being able to do two things: look at equity, access, social determinants of conditions in health related data that's integrated, and be able to look at integrated care and break out of our model of state-based or state-funded hospital care and primary care. And I think I'll ask all of our panel members to comment on this. But one of the solutions, for example, that we're looking at is we're about to integrate data. I'm not sure if actually the team are online here, but from 1,600 primary care practices in a platform that can then be linked to the acute health service data for that same population. And once you start to see these sorts of things happen, I think you're going to get real transformations. And there's not many settings where that does occur, but being able to do that is really important. And perhaps if I can go to you, Wendy, next. Did you want to make any comments about integrating community and hospital care? Just one thing to highlight there, which I say to my CEOs all the time: 1 in 1,000 Australians are admitted to our hospitals every year, and many of them are either for birth, surgical events, or end-of-life care. Yet 790 of them see their GP every year. And if we really think we're going to change health by focusing on hospitals, that we may as well go find a paddock somewhere to have a picnic. So Wendy, over to you.
Yeah, I think it's a really important point, and it's why people want to call, this the learning health system, because there's all kinds of information that we need, even outside of, allied health and GP care. There's the grocery shopping data, there's environmental data, there's information about what magazines people subscribe to. There's so much data available to us about our patients and about each other that we could potentially be using. And I think that integrated healthcare systems like University of Pittsburgh Medical Center in the US have been working on this for a decade, because they've had that integration and they're pulling in all kinds of data outside of clinical data that helps them make, get better outcomes. And so I think learning from them about how to integrate that. But then there also seem to be a lot of different attitudes here in Australia about accessing data and sharing data. And coming from the US, it was a shock to me to hear people refer to their surgeon as Big Brother, because I had never, we of course see the bias in the medical community from the business side and with hospitals from the business side, but I've never affiliated it with government before. And that's a whole new layer of, biases and worries that people have about capturing all this data.
Wendy, I think you're being very diplomatic there. Claire, did you have any comment about integration with primary care?
Oh, look, I think the biggest hurdle we have at the moment is funding and legislation. So I think that we all know what should happen, and it's always sort of vaguely entertaining when someone says to me, "This should be integrated." I'm like, yes, I know it should be. So I don't think it's a lack of vision or a lack of will, but there are significant funding and legislative barriers that I think need to be dealt with. At the moment, it's almost impossible to deal with them outside of a research context, which goes against the very idea of a learning healthcare system. So I think there needs to be some major structural reform around legislation and around funding to allow the learning health system to encompass the entire continuum of care. So I think it's a major structural reform. I don't think it's a will.
And Helena, can I just add to that? I think that people, think this is something about the health system without realizing it's actually just the structure of Australian healthcare, the federated system we have between states and jurisdictions. And I do quite a lot of work in Boston. I've worked with Callum McRae and I sat with his virtual navigators in Boston, in Brigham, and they got 2 screens, one with the full primary care data on it integrated, and then one with the acute care data sets just next. And it's just they can't comprehend that you can't have those 2 data sets together. So it's obviously Wendy would experience that from her time in the US. It's an artificiality here. I mean, obviously they get into huge problems when you move between systems and things in the US, but the fact that we have that break is just fundamentally flawed, and I think it's something we really have to address.
So you can go and take up the charge there. I can't say I had those discussions with Treasury many years ago, Tim, and the answer the answer was that 54% of the state's budget. So I may be wrong here, but the answer given to me by Premier and Cabinet, my Prime Minister and Cabinet was 54% of the state's budget is health related. You're never going to extract that from the states, or pretty much they won't have a budget. So without trying to change that, there are data solutions to this, and indeed the project that Anna's doing, bringing on the primary care partners with the acute health care partners and demonstrating this is feasible, not just in research, but actually in integrating care, is actually possible. So potentially data is one of the solutions around this. Now, if I can just link back to some of the other questions here. So Patrick asked, you know, if health services are so poor at innovation, why are we worrying about this? The amount of money and investment from our jurisdictions, who are very well intended, and our clinicians and our health services that's spent on innovation and improvement without scalable, implementable impact is concerning, and even more personal conflict or personal interest declared. The up to $300 million that is spent in Australia every year on health consultancies, usually focused on improving the system, for which there is no evidence of improvement. When you actually think about everything that's spent, and then you look at examples where there is evidence that you can make it work, and it does work, and the evidence for that is exactly the point of the learning health system, Patrick, bringing in all those elements. There is evidence that this works and that this can improve. And I agree with Tim and Claire that our system is poorly integrated, and Kaiser Permanente is a beautiful example. They actually run healthcare right from population health and prevention all the way through primary care through to acute care. And so they actually have a vested interest in making the system work, and they use data really well. And they actually reached out to us as a thought partner in this learning health system space. So there are learnings we can take from others, but I suppose the point is there is ways of innovating and improving. And indeed, that's a journey that we've been working very hard with our health services on in terms of driving improvement. It's a primary role of the academic health science centres to support and enable. We've been working very closely with groups. For example, the health department have just put 30 people funded through our implementation program to build capacity and train and start to build people in the policy context. Many of them were clinicians, and also putting a large number of clinicians through this. So it can be done. It just can't be done the way we do it at the moment. So a lot of opportunities to move forward on that. Anyone else want to make a comment on that?
Yes, I wouldn't mind saying something.
Yeah,
so I think too there are pockets of innovation and implementation of change that work exceedingly well, and the problem that I see is being able to do that across the system and in a way that builds on other people's work, and that's the beauty of this learning health system approach that we're looking at.
Very good point. And I think that's the issue that, you know, while there's pockets, the challenges are around sustainability, but scalability is the biggest problem. And indeed, the research around how healthcare services do improvement or quality improvement shows that the most important factor for people who want to implement change is where they sit in the governance structure and how close they are to the CEO. And the factors that they least prioritise are consumer and community involvement and bringing in evidence and learnings from other organisations. So you can see how there's just examples for culture change there that would change things dramatically. And so look, I think they're the main questions. I don't think there are any major ones that we've missed. Can I just go around the panel and ask for any additional questions or comments? Sorry, beg your pardon. And we'll just see if there's any final questions. So you're the first on my screen there, Claire. Any additional comments?
I don't think so, no.
Okay, great. We're all going to move to Queensland, not only because you have no COVID cases, but you've got centralised data and a nice weather.
Helena?
On a lighter note, you've got no cases today. Wendy, any comments from you?
Just that it's very complex, and like Claire said, you know, it's a very complex adaptive system, and to innovate in the healthcare space requires so many different disciplines coming together, and all the pieces are there, like everyone has said. It's how do we really bring them together so that we're thinking about the end from the very beginning, and then you know, testing things out a little piece at a time so that we de-risk them and get them ready, and then demonstrating the evidence.
That's great, Wendy. Actually, that links to a question we didn't answer, which was about the learning health system, whether it's always clinician-led, and the fact that there are many others, such as innovators and change, economists, epidemiologists, implementation people that need to link into that, and the fact that we don't have that workforce in Australia. You may want to comment from a US perspective, but it is fair to say that they are all critical, as Wendy said, in the learning health system. You actually can't do it without all those. But the learnings from the UK are that it does generally need to be clinician and stakeholder led on the ground. And one of the reasons for that is that in the UK, they ended up building quite a big workforce, and they were a bit like a fire department. So a problem occurred, and they would, in fact, I had the fortune of working with or meeting one of the leaders of implementation science and research in the UK just before her retirement. And I said to her, what would you do again and what wouldn't you do? And she cast a hand over this group of 200 plus experts with all these sets of expertise we're talking about. And she said, I wouldn't create this. And I said, why not? And her comment was, we are basically the fire brigade. We go in, we fix and we leave, and we don't have any capacity for the system to then go on and improve itself. And they just become reliant on us and they don't build the capacity, and we just can't, we don't have the workforce to do that. So I was going to do it again. What I would do is build capacity, like the program that Wendy's describing, like the work that we're delivering with Monash Partners, etc., about building that capability that sits within the system and making it everyone's business, and working with our policymakers to make it a critical issue for CEOs as well. So Wendy, did you want to comment on that at all, about the role of all those other health professionals and non-health professionals? No? Okay. Dominic, any additional comments at all?
I'm just really pleased to have been part of this session and to hear about all these fantastic programs. And I'm really grateful that there are the toolkits and resources available, and we're going to stop reinventing the wheel. And I think it really is important to continue to have forums like this where we can be across and have the connections to not work in silos, but to actually leverage from the wonderful work that everyone is doing in this space, so we can build that capacity from the ground up, but learn from others as part of a learning health system ourselves.
In fact, when we put some of our experts together, so Rob Sterling's on the line as well, when we put the lung cancer team, the Dominic stroke team, and the diabetes team led by Sophia Zungus and others together, we all started talking about how we were going to run those projects through the learning health system. And the diabetes leads was saying to Dominic, oh, you've done that. We really want to be able to do that. How did you do it? And vice versa. There were some things the diabetes team did that Dominic was quite interested in. So instantly, just in the setting of developing up this system, they started learning and sharing. So I think that's brilliant. Anna, anything else you wanted to add?
Thanks, Helena. Really just piggybacking off Dominique's sentiments, I think if I've learned anything leading this project, it's just that the collaboration amongst the health services along with, Monash University, and just the sharing of learnings already has just been invaluable. And we want to, make sure that that is ongoing. And obviously, as we get towards the end of this, that will be something that we'll be really keen to do, so that it just doesn't become, we just don't want this work to start and end with the project. And again, our goal is to use the Monash Partners Learning Health System to support the changes that this project will bring about. So those are just my final thoughts.
Thank you, Alison. Not last but not least, given you've driven so much of this work for so long.
It's been a pleasure. I think the application of this approach is quite logical when you start looking at issues and problems and the data that you've got within your service or within your reach. And whenever people mention getting stuck in an implementation or a change management process, if you go back to this structural system, it's very clear to see why that's occurring.
Yeah, excellent, thank you. And we just had another question actually from Jun Yang about how you go about changing policies and guidelines. So that's a long question, answer I would suspect. But I think that it's fair to say, having done it multiple times myself, one of the most important things is to work with your consumers. They are a very powerful voice to government and policymakers, in fact, probably more trusted than the clinician academic. When I go to work with policymakers, I actually usually have the consumers do the initial conversation, where I'm either not in the room or myself and my team don't come in until afterwards. The priorities and needs are set by the community group with background formative work, and then the experts come in to say, and this is how we're going to help, and we're partnering, and that's been really, really important. And actually building capacity in your consumers, I can see that, John. One of the things about the Monash Partners system for consumer and community involvement is we will help build that consumer and community involvement group. So there's actually training for consumers. And I don't mean lobby group consumers, I mean really genuine consumers, end users, people who are genuinely wanting to make sure that the system works for them. So we actually can train them and build capacity in those groups for you, and they become really, really vital. And Angela Jones is the best link there. I've also put my email and Alison Johnson's email, and Wendy put hers in there earlier. So if you want any of those contacts, come back to us. And yes, Andrew, the academic health science centres are exactly that. They are learning health systems. And the idea here is they can move beyond projects. I would suggest to you that it's nobody else's job to fix or look at the whole system at the moment. Federal and state, unfortunately, don't align academics, consumers, health services, but actually the job of the academic health science centres or the research translation centres is to do exactly that. And that's what the NHMRC is looking to partner with us in terms of doing that on a national level. So I'm going to stop there. I don't think we've got any other questions. Thank you so much for your participation. Brilliant panel. Thanks, Tim, for jumping in there at the last minute as well. Thank you, Wendy and Claire, Alison, Anna, Angela. Really fantastic. And please reach out to us if you want any of that information. And feel free to explore the Monash Partners website on any of those things, from effective implementation, consumer and community involvement, the data-driven initiatives, especially what we didn't get time to talk about today, which is all the different components from data sharing, data governance, data sharing principles. The really exciting opportunity, sorry, I'm going to be slightly partisan here and say Monash University currently holds a contract for the national data storage system that's used in the UK across the NHS, but also is the partner for the CogStack platform, which is their artificial intelligence, and is bringing in FHIR. So by bringing in those sorts of initiatives together, we've got some really great power to be able to work together. We're working with Queensland on that as well. Thank you so much, everybody. 2 minutes to go. Have a lovely evening.
Thanks, everyone.